Welcome back to the Bloomberg American Health Summit. Please welcome Dr. Kadija Ferryman, faculty at Johns Hopkins Berman Institute of Bioethics, and assistant professor, Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. Dr. Irene Dankwa-Mullan, Chief Health Officer at Marti Health and board member of Hurone-AI, in conversation with Dr. Elizabeth Stuart, Bloomberg Professor of American Health, Department of Biostatistics at Johns Hopkins Bloomberg School of Public Health.
Welcome back. Thank you all for coming back from the break. Really happy to be here with you all. And I feel like it can't be a symposium like this without some discussion of AI right now. So we're happy to have our 8 minutes on AI. And I think the thing I want to start with is we've already heard a bunch of themes today about data and evidence. And in some ways, AI isn't new to public health in that regard, like focus on data, computational tools. I think what's different is the scale and the potential scope. And I think when we think about AI, one of the two features that I might highlight right now, one is sort of this ability of computers to do what we think of as human reasoning. We'll come back to that. And then also the fact that it learns from itself. And I think that is what makes it both powerful, but also have some potential pitfalls. So that's what we're hoping to really dig into today. But again, I want to sort of stress that at the heart of AI is data, and I think we'll be hearing again about sort of both what the good and bad aspects of that. We're going to hear some examples from our two panelists about the role of possible applications of AI in public health to just to kind of give some initial ideas. I've within the School of Public Health at Hopkins, we have people working on TB screening in rural areas where AI is enabling mobile units to go and do screening and then provide point-of-care treatment for people who actually test positive, sort of in the field, much more automated than has been possible in the past. Another, you might have heard at previous summits about work on suicide risk prediction models within the White Mountain Apache tribe, and using that to identify people at risk and then intervene, and that led to reductions in suicidal behavior in those communities. So I think, again, there's a lot of promise, but we know that there's concerns about representativeness and this automated process, and sometimes that sort of black box nature. So we're going to, again, have a little bit of time to talk briefly about some of these checks and balances and ways to think. So let me turn first to Dr. Ferryman. So can you tell us a little bit more about some of the data inputs used to build AI tools and then the implications for their use in public health practice?
Yes, absolutely. So I'll give two examples. One example is the All of Us research program, which if you haven't heard of it, it's funded by the National Institutes of Health, and it's on track to be the largest research study ever in history. The goal is to enroll 1 million people in the United States in the All of Us research program. At this point, 850,000 people have been enrolled. And the All of Us research program, although technically not a public health program, because it is enrolling so many participants and there is so much data, right? We can learn a lot about population health and public health from the All of Us research program. And so there have been really great examples of research using AI with the All of Us research program data. So for example, researchers have used AI and machine learning to do things with All of Us data like predict weight gain, to predict uncontrolled diabetes, to predict glaucoma. And one thing I want to stress about the All of Us research program, not only is it a huge program and so there's big data, from the very beginning, the All of Us research program has been really intentional about enrolling a diverse set of participants, right? So the goal has really been to engage communities, populations who've been underrepresented in research in the past. So this makes it a really promising example of how AI can be used for population health, for public health, health when there is data representativeness, when there's a diversity of participants. Now let me just follow up with one quick example that shows sort of the other side. So researchers, as Liz mentioned, have been using, public health researchers using AI to do things like predict disease onset, epidemics, things like that. So there was a recent study using large language models. You might know those as the chat GPT type things. So using a large language model to actually analyze tweets from people in various countries to see if tweets could be used to predict an infectious disease epidemic. And this large language model did really well. It actually did a really good job at predicting when there would be outbreaks of infectious disease, except when they looked at tweets from the country of Haiti in the Caribbean. And that is because Haitian Creole was not as well represented in the tweets in the data that the large language model was analyzing. So that's an example where when you have unrepresentative data, it leads to bias and it leads to these AI tools not working as well for public health and for our public health goals.
Thanks, and I think a nice reminder that some of the evaluation tools that you all have been learning are still going to be incredibly important to help us be able to study those sorts of issues and how they are or are not working. So Dr. Dankwa-Mullan, I know you work a lot with AI tools in practice. Can you give us a little bit of examples of successful implementation of AI in public health?
Yeah, sure, happy to. So I would start by saying that successful implementation of AI in public health really requires a strong data governance. It requires a modernized infrastructure, so a good, really robust data architecture. It requires a trained workforce. It also requires strategic collaborations with not just physicians or health professionals, but also with the community. And most important, it also requires an ethical framework to really detect fairness and transparency. So what I'll say is that there are no, what we have right now are not really good, fully scalable, stable success stories remain rare, especially in public health. And what we have are actually promising practices, right, that are being implemented in collaboration with health departments, in academia or public-private partnerships. And some examples are, epi surveillance that you mentioned, looking at outbreaks where they use social media, where you can also use environmental data. And so we have those kinds, epidemiologic and disease surveillance. There's also predictive modeling, where it's being used to sort of detect, looking at emergency room visits or looking at, environmental data so that they could, figure out where AI could, or an intervention in public health could make an impact. A lot of these really rely on quality data, and which is lacking, and so there is some sort of a deficit there. There's also successful models in predicting asthma outbreaks, so environmental data using geospatial modeling, that's also going on. And a fourth example I'll use is also digital health communication. There's NLP being used in chatbots to communicate health messages, but some of those data also miss the local nuance or cultural values being put in the data. So there are some promising practices, but I wouldn't, I think we're yet to get there where we would have successful AI implementation.
Great, thank you. I think we're unfortunately already out of time, but we can clearly lots that we can follow up in with future conversations and maybe even over lunch. So thank you so much for bringing your expertise to us today.
Yeah, thank you.